Hello and welcome to the next episode on patient education around knee replacement. This is paired with the book I have recently published, The Proactive Approach to Knee Replacement. I'm Dr. David Graybill. Today we're going to talk about my second episode on complication reduction. There are many of these topics out there. I've chosen three. One on lifestyle, one on medical, and one on physical limitations. And here we're going to talk about a specific medical problem where intervention can have a very significant impact on your complication rate, specifically the risk of infection, deep, superficial, and wound problems. So I hope you'll find this helpful. I think this is best paired with my book, which is available on Amazon Kindle, Apple Books, Barnes & Noble, and BookBaby, who is the publisher. So moving on to the specific of the topic, a modifiable medical problem we're going to discuss today is type 2 diabetes. I'm going to separate this from type 1 diabetes because type 1 diabetes is essentially always requires insulin. If you have type 1 diabetes, you're on insulin or aggressive anti-diabetic treatment, you need to coordinate with your endocrinologist on this. Here I'm assuming type 2 diabetes is present in a patient and they're either on diet control or metformin. If you're not on metformin, and you have a high A1c, I would strongly encourage talking to your physician about metformin. Metformin does improve your metabolic function and has a good risk profile and is I think a perhaps somewhat underused medication, particularly in the pre-diabetic level. So here's a fact. Elevated blood sugars around surgery are associated with more wound problems and infections. As we discussed in last episode on protein, deep infections, wound problems are potentially catastrophic. Again, I go over some of this in the book, didn't mention it last episode, but if you develop a deep infection, you always will need additional surgical intervention. It'll be difficult to get as good of a result as you would have if you didn't have an infection. Many times the prosthesis actually has to be removed to cure the infection. So this is something best avoided, not left to randomness. So this is why, actually it's one of the reasons I wrote this book, because patients do have a significant impact on their own outcome, and the surgeon really can't control your diabetes before surgery, control what you eat, etc. So it's important, I think, to modify this issue or problem. So we'll go over a little bit of that as we continue the talk. So first, a couple more facts. Number one, surgery in and of itself, even in a non-diabetic, results in stress hormone release, cortisol specifically, and this raises blood sugars. The vast majority of patients also receive steroids around surgery, as it's been proven to improve pain control, nausea, and overall outcomes. However, the corollary is this drives up blood sugar levels. There's some literature, again, I'm not going to quote exact articles in this talk, but there are a number of articles that suggest that even a single peak of a blood sugar above 180, possibly 160, can increase the infection level. And that this could, if this occurs particularly in the immediate pre- and post-operative level, there the impact is higher. I think as long as we have an open wound, it's very important to not have elevated blood sugars. So even if you're a non-diabetic, please watch your carbohydrates and starches before and after surgery. If you're in the recovery room and they offer you a drink, choose a non-sugar drink, so avoid juice, Coke, Sprite, things like that. Choose a diet drink, water, something along those lines. So another well-established fact is the better our preoperative blood sugar control, the less elevation of blood sugars we see after surgery. Commonly, there is a test, we'll be talking about it shortly, the A1c. I'm going to mention an unofficial study that was done through our clinic. We had a preoperative clinic prior to surgery that I helped institute at several of the hospitals I worked at. One of the hospitals, one of the nurses, as her NP project, started looking at blood sugar control around surgery, and we had A1c on all patients. And one interesting fact was even people that didn't quite qualify for diabetes still had a substantial increase in risk of a elevated blood sugar, defined it over 180 in the postoperative period. This was done at a time when patients were still staying in the hospital for a couple days after surgery. And we found that insulin resistance, which is what we're talking about with diabetes, can even be present in people with an A1c of 5.7 or less. So some of these things that we're talking about also apply, and likely do apply, to patients that have what is considered pre-diabetes, which would be an A1c 5.7 or less. So an overall strategy for patients, everyone I think should have a preoperative hemoglobin A1c level drawn. And this should be done as soon as possible, not immediately before surgery, because the A1c is a test of the average daily blood sugars over the last roughly 3 months. And it isn't something you can rapidly change. So the earlier you know if you have insulin resistance, the earlier you can improve it. So here's kind of a general guideline. This doesn't need to be followed exactly, but I think it gives a good general approach. If your A1c is below 6, you are favorable. Okay, you don't require dramatic changes. You don't want to slip off your diet. But I would still recommend watching your starches and carbs for 2 weeks before and 2 weeks after surgery to a little lower than what your current baseline diet is. Again, the stress of surgery, even if our hemoglobin A1c is well controlled, can still significantly elevate our blood sugar, and we want to be careful. The opposite extreme is what I would consider, and most surgeons would consider, a very high A1c. That's 8.0 and above. In this situation, I think surgery is actually not appropriate electively, and it's wise to delay the surgery. If you're above 8, this is probably not something to approach on your own. You should consult your endocrinologist and get aggressive at your diabetes control. This may involve adding medications, changing medications, and certainly changing your diet. Again, it's going to take several months to improve your A1c level to a safer point. You don't always have to wait for the A1c to fully correct. If you can document excellent blood sugar control at multiple points during a day, during a number of days in a row, to prove that it's safe, but we really want to dramatically improve blood sugar control if you're in this situation. So in my own practice, patients were above 8. They got sent to an endocrinologist. We got them one if they didn't have one already. And they worked with that physician for typically at least a couple months. And then when blood sugar control was documented through means that it was much improved, we would reschedule. And lastly, probably where most patients are going to fall are between 6 and 8. Again, this is a graduated thing. Obviously, a 6.2 isn't the same as a 7.8. If you're very close to 6, you probably can approach things similar to those below 6. The higher you are, the longer it's going to take to trend improvement. So maybe we're around 7. Wouldn't have surgery in the next week or two. I'd probably schedule out a couple months. And then a reasonable goal, again, this is for people that are on metformin or no other diabetes medicine. A reasonable goal might be 60 grams of carb a day. We do not want to get or become ketotic. We do not want to have our blood sugars get too low. Some of the medications, many of the medications beyond metformin, can take our blood sugars dangerously low. So we have to be careful and involve a medical physician if you're on medicines aside from metformin as we reduce our carbohydrate levels. So that's kind of my general approach for patients. I hope this is a hopeful guideline. Obviously, each individual has to approach this differently. And if there's any doubt, pursue medical evaluation. I think blood sugar control is more recognized today as a significant factor in wound problems and infection, but less so by patients themselves. It's extremely important in my view. I have a relatively low A1c. I've had both my knees and one hip replaced. Each time I got to within a few months of my surgical date, I took my carb levels lower, tried to stay close to that 60 grams, and at the same time increased my protein levels, as discussed in the last talk, closer to a gram of protein per pound of body weight in order to minimize my chances of devastating wound problems. So I hope this is helpful. Again, this talk pairs nicely with my book. There's more detail and references in the book itself, so I encourage you to look there. This is the second on our complication reduction lectures. The next one, I'm going to cover a physical limitation. Again, there are many of those. I hope this is helpful, and have a wonderful day. Thank you.